I'm Christina. Thank you so much for coming to this presentation today. It's called Paediatric ECGs, and I like to think that they're Pandora's boxes, because if you're not really sure where to start and where to go and what to do, you can open up a can of worms. So because I'm really passionate about ECGs and about how the heart works in general, I thought about making a short session today to help you first of all understand how ECGs work, do a bit of recap from that point of view, especially because I'm mindful that I've got a wide variety of healthcare professionals joining today. Developing a structured approach to when it comes to reading ECGs, and last but not least, hopefully improving the confidence in spotting abnormalities on ECGs and how to handle that. First of all, you hopefully know by now, but if you don't, ECGs capture the electrical activity emitted from the heart. It's basically a movement of ions across cell membranes, and that is fundamentally responsible for the activity that happens within the heart. The ECG was invented many years ago, in 1895, and is surprisingly still used today. It's really quick, a really quick investigation that all of us should be able to do, that helps give you a picture, a very quick sort of like spot-on picture of what the heart is doing from an electrical point of view at that point in time. But I think the biggest confusion that I've seen from a lot of people when it comes to pediatrics is how to do an ECG on a small human. Basically, it's just like in adults. You put the leads in the same place, preferably on a bone, rather than a muscle, for obvious reasons, because muscles receive their own electrical impulses. And for the smaller the child is, the smaller the stickers you're going to need. What I sometimes do when the chest is too tiny is to get the usual stickers that we've got and just cut them with a pair of scissors. Doesn't really matter as long as you get a tiny bit of electrode onto the chest wall or limbs. Fresh skin is really difficult to attach stickers to. Newborns are really difficult to stick ECG stickers on. And when it comes to having an ECG done, ideally the patient shouldn't be moving and shouldn't be talking, mainly because the more you move, the more artifacts you cause. So for a baby, what I found really useful is to swaddle them, or to use sucrose, for example, or in other children, distraction. Do anything that you can for that 1 second of capturing an ECG pattern. If somebody is sweaty, what I found really useful is to use opsite spray, something that's worth looking for on your ward, just to spray it onto the skin. Obviously careful not to scare the child, just make them aware that you're going to do that, and stick them on that way. And obviously sort of like how to put the limb leads and the precordial leads, like I said, they're literally the same as in adults. Whether you put them on the shoulders or on the distal side of the arms, it doesn't really matter, as long as you have more or less the same, you do the same thing on both sides. So rather than putting it on the right shoulder and left wrist, make sure that you do it either both shoulders or both wrists, if that makes sense. And the same with the legs.
Christina, what is opsite spray, for those that don't know?
It's a spray that well, to be honest, I don't really know what exactly you can use it for other than drying the skin. I've not used it for anything else. I think it's meant to be clotting the blood, isn't it, or something like that? I don't really know.
I've only ever seen it used for that exact, drying some sweat for an ECG. I haven't actually used it for anything else. Just
Yeah, literally the same. I've seen it used after LPs as well, for example, when we've done LPs, and you just spray it on, because technically it should have sort of like drying properties. But I haven't really used. I don't both put it that way. I don't really know what the actual big purpose of it is, other than being used for various tricks.
Okay, no worries. Yeah, I'll have a quick look. Oh, someone has commented actually. It's a spray on dressing. Thank you,
There
Caroline.
we go.
Ah, well, you know. Thank you.
MDT sort of knowledge. So, for those of you from this presentation, this might be a really boring one if you know all this already, but for those of you that don't really know the difference between electrodes and leads, because we're going to use the term leads quite a lot, basically your heart has loads and loads and loads of electrical activity within itself. It's got a wire system coming from the main battery, which is the SA node. And basically, every single lead reads the sum of the electrical activities, so the sum of those waves. If the wave goes mainly, or the main wave goes towards the electrode, then the lead will be positive. If it goes away from the electrode, then the further away it goes, the more negative it will be. So hopefully that will help you understand what we're going to be talking about in the next many slides. And these leads are based on where the electrodes are placed. So, and now how to actually read pediatric ECGs and ECGs in general. So first of all, it's really important to know who the patient is. When I was working, well, when I work on CAU or when I used to work in A&E, you would be just handed an ECG being like, can you just sign this ECG? Or can you just look at this ECG? And it used to be really confusing because you can miss so much if you don't really know why is that person had an ECG and who are they. So knowing who the patient is really important. How old are they? Have they got any symptoms? Is it something routine? I tend to avoid to look at ECGs or to sign them or to do anything unless I actually have at least 2 minutes to get a bit more information about who the person is that I'm reading the ECG of, simply because it might be seen as something routine, but actually you can find a lot of information from them as well as miss a lot of information. Knowing what settings the ECG is done on, so it should be set on a 10 millimeter per millivolt on the y-axis and 25 millimeter per second on the x-axis, and you will see that at the bottom of the ECG. So make sure that those are the settings that your ECG is done at, because if not, that will alter what your ECG is going to look like in terms of height of voltages, artifacts, etc. Like I said, find out what the age of the child is, and we're going to talk about why in a second, and also the reason. In terms of calculations, because we're going to have to do some maths. One small square is 0.04 seconds, and a large square is 0.2 seconds. Don't worry if you don't remember this. The more you do it, the more this will turn into a reflex. But if you don't do it often, it's absolutely just as fine to Google how much a small square and how much a large square is on an ECG, because I can promise you many people forget. From the beginning, when it comes to reading an ECG, all of the big pediatric cardiologists that you show an ECG to will be reading an ECG through the same structure. It might not seem like it because they don't word what they do out loud, but actually everybody has a structure in terms of reading, or at least the biggest cardiologists have a structure when it comes to reading ECGs. If you don't, you're more likely to forget. More or less the same as we take histories. For now, it's become a reflex, and the more histories you take, the quicker it gets. This applies for ECGs as well. So, are P waves present? So is there atrial activity? And we're going to talk about the P wave in a second. What's the rate? And is it rhythmic? Is there rhythm or is it arrhythmic? And the way I tend to read the rate, and it's something that I was taught in medical school, doesn't really apply for everybody, is I calculate the rate based on the big squares. So if you start at the R wave, just like in the picture on the second half, like lower half, and I count down 300, then 150, 100, 75, 60, and that's per big square. So sort of like every bolded line is a target. So 300, 150, 100. If that makes sense. It doesn't give you the exactest of numbers, but it gives you a rough idea as to what the heart rate is, rather than having to take your calculator out. In terms of P waves, it's really important, other than whether they're present or not, what they look like. If they are peaked, if they're humped, and hopefully this picture will help you understand why some P waves are peaked and why some P waves are humped. So they have two humps, because mainly what we see on a normal ECG is one P wave, but actually if we were to zoom in a lot into a P wave, it would actually have two very small humps, because the SA node is located in your right atrium. So it obviously sends the electrical impulse in the right atrium first, and then with a tiny lag, the electrical impulse goes into the left atrium as well. Which is why if you have a big right atrium, you're going to need more power. So your wave, the slower it's going to need to depolarize the atrium. So to activate the atrium, the taller your wave is going to be. If your left atrium is big, so therefore you're going to need a lot more power to activate your left atrium, the wider the second half, the blue triangle is going to be. So therefore you're going to see a hump or a lag. Technically, we should be looking at the P wave axis as well. It's quite important to look at that, but if you're doing a glanced reading of an ECG, that's you can get away without doing that. Okay, so because I thought about what would make this more interesting, because ECGs tend to be really dry, I've made a Kahoot quiz that we're going to be going back and forth to throughout the presentation to try and do a bit of practice as well. You don't have to know everything. That's why this presentation exists. But hopefully this should make it fun. So grab your phones or open another browser. I'm going to stop the volume from my end. So go on to kahoot.it, type the pin in and join the game, because we'll be doing some practice along the way. You can use nicknames. You don't have to use your actual name. I usually use nicknames. And don't worry if you're not joining at this. Anybody can join at any point in time. So if it does log you out or kick you out, feel free to join back in. That being said, I'm not really sure if there is an actual limit of how many people can join, but hopefully there isn't going to be one. I'm going to wait for a little bit longer. Super. I'm going to start, but the game pin and the address is going to be present on the screen all throughout. So don't worry if you haven't. So we've got this ECG. What do you think roughly might be happening? We're obviously at the topic of P waves. And there's no such thing. I'm not expecting you to know the answer. So the right answer was dextrocardia. Let's go back to the presentation and think about why. So in dextrocardia, we have a reversal of the R wave progression, and also you have negative P waves in V1 with a deranged P axis. And the reason why that happens is if you have dextrocardia and you put the leads in the normal place, your atrias are going to be mirrored. So the electrical activity is going to be captured in the opposite way in compared to having a heart on the left-hand side, unless you put the leads on the right-hand side. So if you put the leads as you're used to putting them, the P wave is going to be negative because the electrical impulse, the mean of the electrical impulse, instead of going towards the left-hand side, as it would normally do, will go to the right-hand side, so towards the mirror orientation of the heart. So everything is going to be mirrored, so the opposite. Now, we're going to have a second question based on P waves. There is a syndrome that has dextrocardia as part of it. It's a very common question in the MRC-PCH clinical, well, in the MRC-PCH exams. Again, don't worry if you don't know. It was Cartagena, so well done for those 16 of you that have answered. Cartagena syndrome is a syndrome in which dextrocardia and actually situs inversus totalis is part of a triad, as well as perinasal sinusitis and bronchiectasis. You would think you don't see it that often, but I teach medical students, and for the second year exams, one of the patients that was brought for the examination was actually a 70-year-old that probably had Cartagena syndrome, which was really interesting. So moving on from the P wave, we've established that it is important to think about how our atrias are being charged with electric impulse. Moving on from the P wave towards the ventricles, we have the PR interval. So what happens in between the atrial charging and the ventricle charging with electricity? Children, the more they grow and the bigger their bodies are and the more mature their heart is, the more the heart rate changes, but at the same time, all the components from an ECG point of view of their PQRS. So the QRS axis changes, the PR interval changes, the QRS interval changes, etc. But do not worry, as long as you're aware that this is the case when you're going to see an ECG, at least you'll know to look it up rather than panic about it. I don't really think anybody remembers the change in heart rate exactly for every single age range, or at least I don't. My memory with numbers isn't that good, but it's something to be aware of when it comes to calculating your intervals. Next ECG, so we're at the topic of the PR interval. Technically, your PR interval shouldn't be more than 3 small squares. That's usually roughly what you should be looking at. That's what they teach you in adult medicine. But obviously, the quicker the heart rate, the smaller the PR interval is going to be, which is why knowing to look up what the normal intervals are in ages is important. So this is going to be a test on PR intervals. What do you think is happening here? If you don't know, again, don't worry, because we're going to learn about it on the next slide. So what does the PR interval look like? Is it short or is it long? And then what do you think might be happening? You can just randomly choose an answer. It doesn't matter that much. So yes, it was Wolff, Parkinson, White. So well done for those of you that have chosen that. So the PR interval here was really short. There's basically it's less than one small square space between the P wave and the R wave. The R wave is humped. And the reason why the R wave is humped is because you've got an accessory pathway, which is what Wolff, Parkinson, White is based on, that tries to do its own thing and to depolarize early, which is why, so to propagate the electrical impulse early, which is why your R wave is slurred. And we're going to talk about it again, or mention it again towards the end of the session. As you go lower down from the SA node, so the main battery of the heart, from the atrium to the ventricles, so through all the wires, at some point you might have a bundle branch, so a branch of your bundle of His, which is the main wire, or represents the main wires that go through the ventricles. You might have abnormalities of those bundle branches. And whilst you go through the AV node, you might get a block in the AV or through the main branches. And if that happens, you might be getting something called a AV block. So it's quite difficult to remember which one of them is which. The way I remembered, I used to sort of like think about them as relationships. So if you have a nice relationship with your friend, you're the P wave, they're the QRS, you get along really well, you're really close. But then once a blockage between you happens, for example, a pandemic, and you're not able to see each other, you become more distant. The more distant you become, obviously, the more severe the block is. If it's a first degree AV block, then you don't try to reconciliate with each other. Nothing happens. You're just distant from each other. If it's a second degree, if it's a Mobitz 1 or a Winky back, you are distant from each other. You don't try to reconciliate. Well, you try sort of like gradually to reconciliate until there's nothing left to do and your friendship falls apart. A Mobitz type 2 friendship, where you don't think anything's wrong between yourselves, but all of a sudden your friend just disappears. And then a third degree AV block where you just have your lives separate from each other. So the P waves have no relationship with the ventricles whatsoever. They both depolarize each other separately. Hopefully that hasn't made you more confused about the bundle blocks at all. But we're going to practice that in a second anyway. When it comes to the QRS complex, so the QRS complex represents the electrical charge of the ventricles. It's really important to look at whether is the QRS broad, is the QRS narrow, what does the QRS look like? So what do every single element look like? What does the Q wave look like? Is there a Q wave? What does the R wave look like? What does the S wave look like? And a very helpful way of thinking about it is the QRS long? Are the R wave or S waves tall or deep? And when it comes to the axis, the easiest way I found in terms of calculating the axis is looking at D1 and AVF, so lead 1 and AVF, because lead 1, if we go back at the beginning, lead 1 is the horizontal lead, isn't it? And AVF is the vertical lead, and if you unite them together, you get a 90 degrees angle. In order to calculate the axis, I usually look at how positive or how negative each of them are, and then according to that, I imagine myself as having an axis going horizontally through me or through the patient, and also vertically. And according to whether AVF is positive or negative, or lead 1 is positive or negative, I roughly imagine where the axis is going to be. So if it's right axis QRS, sort of like in the right inferior quadrant, right superior quadrant, left inferior quadrant, and left superior quadrant. And that's usually more or less what you need to know. Knowing the exact number on a glance isn't the most helpful of things. So if you're thinking about calculating the QRS axis or thinking about whether it's negative or positive, in my advice, this would be the easiest way of thinking about it. And hopefully these slides will be shared with you. If they're not, taking a picture of that circle that explains where lead 1 is positive and where it's negative, same as AVF, should hopefully be a bit more helpful. That's what I found really helpful.
Yeah, we can upload the slides after the session onto Medal.
Amazing, thank you. In paediatrics, there are some quirks and some things that are normal compared to some things that aren't normal in adult ECGs. When it comes to RVH, you might have or might have not heard the fact that babies are born with physiological right-sided hypertrophy or right ventricular hypertrophy, which is why you will see an element of RVH on an ECG. The most accurate lead to use for right ventricular hypertrophy is usually V1, especially if you think about where V1 is placed for your first precordial lead, because it's the rightest of the precordial leads, it's obviously going to be the most useful. If you've got RVH, therefore more energy is going to be needed for your right ventricle, therefore it's going to be a lot more positive in your rightest of leads. In the first week of life, because you've got an element of RVH, an upright T wave is going to be normal, but after 1 week of age, it will be abnormal. The same as thinking about your RSR pattern in V1, that again, in terms of your first R and your second R, if your second R is taller than your first R, then that is abnormal. And if you have a pure R wave in V1 rather than having an element of S, that again over 6 months of age is abnormal, and that's due to the lag in between reversing or switching from RVH to a normal heart muscle. When it comes to your left ventricle, using V6 is probably the best lead in terms of analysing whether you've got left ventricular hypertrophy or not, because that's the furthest or the leftist of your precordial leads. This is again another reminder of how tall your R waves and your S waves are, both in, or how deep, both in V1 and V6 per age. And this is a really good example of hypertrophy. Your R waves aren't meant to go over the baseline or the isoelectric line of the above lead reading. We can't be talking about QRS without moving on to the ST segment. So once your heart is charged from an electrical point of view, it will have to uncharge at some point, so to depolarize. The ST segment is that time in between those two processes. When it comes to pediatrics, very important bits to remember is that unlike adults, you can have, in pediatrics, you can have ST depressions that are normal. So in a limb lead, ST depression or elevation of up to 1 millimeter or 2 millimeters in the left precordial lead is normal. You can have G-point depression as long as it's depressed without sustained ST depression. And you can have benign early repolarization in teenagers, where the ST segment is elevated and concave in leads with an upright T wave. And they sometimes look like half of a smile. If you imagine your R wave being the nose and the concavity being half a smile, you can already see that they look like half smiley faces. When it comes to ST segments, you're not so likely to see myocardial infarctions in peds. They're still possible, but really, really rare. However, when it comes to ST abnormalities, you're more likely to see bragadas, which is something that you shouldn't be missing. These children will present with histories like collapses, or you might just find them incidentally when you do an ECG for a totally different reason. So regardless of the bragada type, if you notice something like this is something that you shouldn't be missing, especially with a positive history. We're going to get to some exercises in a minute, I promise. We'll end with the dry bits soon. When it comes to your T wave, so your heart was charged, started decharging or uncharging, and now it's uncharged, so repolarized. Your T wave represents the repolarization process. And what does it look like? In V1, it's positive in newborns and should reverse by day 7. If not, then it's pathological RVH rather than physiological RVH. So please remember that. And when it comes to your QTC, so the interval between your Q wave and after your T wave, you've got the formula on the screen, but there are calculators such as MedCalc that can calculate your QTC for you. As long as you get the QTC number, then at least, or the QTC calculation, then you can look up whether it's normal or abnormal as per age. When it comes to infants of less than 6 months, your QTC should be less than 0.49 seconds. When it comes to older than 6 months, so any child older than 6 months should have a QTC of less than 0.44 seconds. But as long as you remember that it's different between 6 months and after 6 months, and you know where to look up the calculation or a calculator for the QTC, that's, in my opinion, all you need to do. So let's go back to Kahoot for a QTC question.
So just so you know, Cristina, a few people are having issues with the Kahoot. I don't know if it's possible to slow it down, because I think there's a slight lag between the Kahoot and the presentation. I don't know if that is something that's possible on your end.
Let me have a look. I don't really think so, because I did look at that when I did the Kahoot quiz today, to be honest. I don't really think there is. No, I honestly did look at this morning, because I did think about the 30 seconds being a bit too little. So I do apologise for that. The question would be around what can prolong your QTC. Myocarditis, hypocalcemia, head injury, Romaner-Ward syndrome. Some examples. and you can select as many as you want. It's not a contest or anything, so this is why I'm not really, don't worry if there is a lag or if you can't answer on time. This is more for everybody's learning. It's not a test. So for the purpose of the QTC and what can cause your QTC to be longer, all of the answers were correct. So from head injury to hypocalcemia, myocarditis, and Romanet-Ward syndrome. Mainly because in order to charge or uncharge, you will need calcium. Your muscles can't function without calcium, so low calcium will extend your QTC, so the charging of your myocardium. Myocarditis is obviously inflammation and inflammation within the myocardium. The inflammatory process will affect the electrical charging of your myocardium, so therefore your QTC will be prolonged. With a head injury, you have the same as ICP. Your automated nervous system or automatic nervous system that has a knock-on effect when it comes to your myocardium. And Romanet-Ward syndrome is, again, a really common reason for a prolonged QTC, if present. Again on QTC, so we've talked about long QTC. What can make your QTC short? And why is it important to find out whether somebody's got a long or a short QTC? Because if you have a long or a short QTC, you're at risk of developing arrhythmias. With a long QTC, you can fix that. So if it's, for example, hypocalcemia, you can give calcium. If it's a drug causing the long QTC, you can stop the drug. If you can't stop the drug, then you can monitor the QTC. If you've got a short QTC, hypercalcemia is a reason. If you can fix that, that's great. Or digitalis, if you give somebody digitalis, you can stop it if you can. But unfortunately, if it's something congenital, and there is such a thing as congenital short QTC, you can't reverse that. So you will have to insert a pacemaker for that. Or not necessarily yourselves, but a pacemaker will have to be inserted for that. So in terms of reasons for prolonged QTC, we've got hypocalcemia, myocarditis, long QT syndrome, such as Romanet-Ward, head injury, drugs, and hypomagnesemia. In short QTC, we have the opposite of hypocalcemia, so hypercalcemia, digitalis. There's such a thing as congenital short QT syndrome. However, hypermagnesemia doesn't have an effect on the myocardium. So hypermagnesemia isn't going to make your QT shorter. The biggest problem when it comes to, one of the biggest confusions when it comes to looking at an ECG is whether something is VT or SVT. And don't worry, even the biggest med regs out there sometimes have a problem when it comes to, or pediatric registrars have a problem when it comes to differentiating between VT and SVT, as long as you remember the fact that you can look up something called Brugada criterias, or have this table somewhere on your phone. That should make it a little bit easier. And something else that will be really helpful is to know that in kids, sort of over 95% of broad complex tachycardias are actually a form of SVT, but with aberrancy. So it's very unlikely, unless there is a reason or a specific underlying cause that you can think about, for a child to have VT. Now that we've spoken about the whole complex and how thought about a way of reading ECGs. So whenever you read an ECG, think about your structure. Have a structure when it comes to reading ECGs. Start with your P wave and go through your P. So your P wave, your PR interval, your QRS, your T wave, your QTC, and your ST. And if you do that, even if you need 5 minutes to read an ECG, that should be okay, because nobody should be rushing you to read an ECG. If it looks like badness and you're really junior, you're obviously expected, or it's okay to ring a senior. But what you should be remembering is that you will be treating the patient in front of you, rather than if it's something acute. So obviously go through your APLS. But if it's just the ECG and the patient is stable, let's go through some cases. But if you're not sure at the end of the day, ask your senior or even call your very friendly cardiologist. That's what they always say, because they'd rather have somebody ask them for help rather than having you worry somewhere in a DGH. Talking about DGHs, let's move on to some cases now. So we're going to have this ECG on Kahoot in a second. You've got a 5-year-old that's under cardiology in a DGH. The patient has a history of proximal tachycardias and have been successfully terminated with adenosine or vagal maneuvers. So he's come to hospital before being really tachycardic, and he either had a vagal maneuver or adenosine done, and that seemed to have worked really well. So what is this ECG? And I suppose in a way that sort of shows why context is really important. Yes, so absolutely. That was SVT. Well done. Don't worry if you didn't know, because it's a very, very difficult ECG to read, and it's really commonly mistaken with VT anyway. But here the context was really important. This was a patient that had had tachycardias in the past that were successfully terminated with adenosine or vagal maneuvers. We've already spoken that over 95% of patients, pediatric patients, will have a form of SVT. And after you did vagal maneuvers, either made them blow through a closed syringe, or if it's a baby, literally put ice over their face. That actually works. Or compressed their eyeballs whilst their eyes are closed. This is their ECG after vagal maneuvers, and you can see delta waves. So therefore, the patient has Wolff-Parkinson-White.
So how does the ice work? What does it cause the baby or child to do?
So if a child has SVT, if you put ice over their face, that activates their parasympathetic response, and it just slows down. It just slows down their heart rate. It doesn't always work, unfortunately, but sometimes it does, and it's a very quick thing to do rather than get a cannula in and use adenosine. If that child is older, then you can just give them a syringe that, like a closed syringe that doesn't have any air in it, doesn't have anything in it, obviously not with a needle at the end, and just make them blow through it, sort of like through the end bit of the syringe, in order to cause a vagal maneuver. So you basically activate your vagus response, which will slow down your heart rate. Did that make sense?
Yeah, that does make sense. Thank you.
You've probably heard about vagal maneuvers in sort of like ALS previously when it comes to adults.
Yeah, the syringe one I've used before with adults and done it in all the ATLS courses and stuff.
Yeah,
The ice was a total new thing.
I know. Well, literally on Peds Cardio, the people who have never seen this before, they usually get freaked out when a baby goes into SVT and the nurses go to the freezer and just bring a bag of ice, and they dunk the baby. Either they dunk it or they put like some ice over their face, obviously wrapped in a towel. Yeah, people tend to be quite freaked out about that. But it does work. Not always, but it does work sometimes. It's worth a try. Next case, and this is a real case. This is a 13-year-old girl that came in with vomiting plus. Whilst in A&E, she developed this rhythm and became unconscious. And I suppose it's safe to think about, is it a broad? Is it a broad PQRS? Is it not? So you're right, it was VT. Unfortunately, and the reason why it was VT, if you think about it, is the patient had been vomiting, so she developed an electrolyte abnormality. It wasn't thought to be VT in that situation, and because the patient wasn't treated accordingly, she unfortunately died. And it was awful to be the one, because I wasn't involved in the case, but I was given the ECG. And I know it sounds really cocky and it shouldn't, and it's okay to not know how to read an ECG in an acute situation, but as long as you escalate it to somebody or ask somebody. But I think it was really sad to be the one to see the ECG during handover, and to kind of, my heart just sank, because yeah, it could have been treated differently, especially if you know your algorithms. Again, why context is really important. The next ECG is going to be about an 11-year-old girl that presents to hospital, and this is her ECG. And what you know is that on her list of medications, she has EPO. What do you think has caused this? If she has EPO?
Yeah, I've got to say it's really interesting actually seeing how much the context affects the ECG. Like, it feels less so in adult medicine, in my opinion, or at least at the level that I work at.
Yes, and I think
there's still some, that is important, but very much like those last two ECGs, I would have, in an adult, said straight away both of them were VT. But then with the added history and stuff, absolutely. Yeah.
So the truth here was hyperkalemia, and it was quite bad hyperkalemia. Initially, in the initial stage of hyperkalemia, you get really, really peaked T waves. But the more hyperkalemic the person is, the more it will inhibit your electrical transmission, and the more you're going to swap towards junctional rhythm, and then eventually towards VT. Or you will see just really weird QRSs that are really, really broad. In this situation, the QRS looks really, really broad and doesn't really look like anything. So this is a typical aspect for hyperkalemia. I mentioned in the quiz something called sort of like sine waves. Sine waves look like sinusoids. So kind of like a rounded dome that is positive and another rounded dome that is negative. And that happens in potassium that is like 9+ or over 9, depending on how sensitive your heart is. And again, that happens because of the more potassium you have. So, which, if you think about it from a biochemical and sort of like biocellular point of view, you have potassium inside your cell rather than outside your cell. So in order to, and if we go back to the initial slide where we have the membrane potential, you will have sodium outside of the membrane and potassium inside the membrane. So the more potassium you have outside the membrane, the more sort of like the more depolarized the cell is going to be, and the more repolarized the cell is going to be, and the more your depolarization will be inhibited. So something to remember when it comes to hyperkalemia. And I know it's something that we learn about in like renal cases in adults, but it actually can happen in children as well. Again, context. So you have a 17-year-old that was rescued after falling in a river, and you know it's November. So we're jumping in time in November, and you get a child that fell into a river. She's usually fit and well. Oh, sorry, jumped to a different case. A 14-year-old girl who's fit and well and had a road traffic accident. Sorry. And it's something that I mentioned when we spoke about ST intervals. Sorry, that was my fault because it was a swap between my slides and the quiz. So on this ECG, if you look at it, you can notice the gross thing that jumps to you is, yes, you have P waves, yes, it is rhythmic, but you have generalized ST elevation. And in this situation, because it's a fit and well girl that's had a road traffic accident, in here you would have had a head injury, so raised ICP, so probably a bleed, because a raised ICP, like I mentioned earlier, will affect your automatic nervous system. So therefore, the way in which your myocardium sort of functions. However, going back to the 17-year-old that was rescued after falling a river in November, for those of you that chose hypothermia earlier, so yeah, absolutely. This was hypothermia. And this finding that you can see on this snippet of an ECG, that little notch after the R wave is called an Osborne wave. You can see it very, very commonly in hypothermia. So if you have a patient that, you just get shoved this ECG in front of you and you're like, who's this ECG from? And if somebody says, oh, it's from that person that was found fallen in a river, you can say, oh, what's their temperature? Because they might be hypothermic. However, you can see it as a normal variant as well. This is another example of a head injury. And here you have something called cerebral waves, cerebral T waves. You can see their amplitude, they're very, very peaked, but negative rather than positive. Apologies that I've jumped again to the head injury bit, but they're quite important because you might see them after a road traffic accident. But in paediatrics, we have children that have a VP shunt, and their shunts can block quite often, and they don't always present with a headache or sun setting. There was a child that I had during my neuro rotation who came in with a very non-specific headache that had been there for 3 weeks. Nobody had thought that her shunt was actually blocked, but it was. She wasn't sunsetting. She was clinically really stable. And I bet my life that if we had done an ECG, something not as dramatic, but something similar would have been on it. Last ECG of the quiz, and then there's going to be one more question. So you have a 15-year-old that presents with chest pain. She has absolutely no past medical history. She comes to the ward walking, chatty. What do you think has happened here? Absolutely. So well done for those of you that have chosen lead mismatch. It's really, really, well, it can happen. It's happened to me whilst I was in one of my rotations. Basically, if the child looks really well, depending obviously on the description of their chest pain, one thing that could have happened is for the lead to be mismatched. And the way you think about that versus dextrocardia, because the P wave is negative in some instances, is that you have arm cable reversal. So in terms of, you might see a different progression from V1 to V6, and that's only one example. But as you can see in lead 1, unlike dextrocardia, your T wave is negative here, which is something that you wouldn't have otherwise seen in dextrocardia. So something to always think about, again, thinking about the context. Who was that ECG of? And what did it show? The way I was referred the child was, oh, I've got a teenager and she's got chest pain and the ECG is really abnormal. So I panicked. We got the child up and she walked in as if nothing was happening. She was she was actually really well. The pain had gone, and I was showing the ECG, and I was actually really gutted because it took us like half an hour to get another ECG done. So be really careful when you get an ECG done, and if you're not the person performing it, if you see that, make sure to think about whether there is the option that the leads were inverted. That being said, I was really naughty when I was an F2 because basically I had a patient that I was really, really worried about on psychiatry. She had an unrecordable temperature, and we tried referring the patient. Basically, I think my reg tried referring the patient. She was refused, and to get her sent to hospital quicker, I reversed the leads myself and hoped that nobody would notice until she got to ED. And nobody did notice until she got to ED. And there she was admitted for over a week with an AKI of 3 and all the drama. But never do that. And last but not least, if when in doubt, if you're worried, whether you're a reg, whether you're a consultant, whether you're a junior or a more junior, an SHO, please call your friendly paediatric cardiologist or senior, because you're never alone. If there's something that you're worried about and you're just not sure what it is, seek advice from someone that does this on a day-to-day basis. The PEDS cardio registrars will usually pass the ECG past the consultant. So don't be worried, honestly, that there will be somebody to help. They are really useful if you recognize the gross features and you sort of know what you're looking for, if you have a structure in your head. But if you get lost, because like I said, ECGs can be Pandora's boxes, there will be somebody there to help you. Don't forget that they exist. They might be in a tertiary centre, they might be busy, they might not give you an answer straight away, but as long as the child is stable, please seek help, because help will be there. They might be grumpy sometimes, but most of the ones I've met were friendly. And thank you so much. Thank you for joining. Please, if you have questions, ask them in the chat bar. If I can't answer the questions, hopefully after going through a short recap, you feel a little bit more confident when it comes to ECGs. If you've never read ECGs before, hopefully this has given you a little bit of a boost of confidence. The slides will be shared with you, and the recording will be available. You can rewatch it anytime. You can message me if needed. My Twitter address was shared into the event, and actually I can write it down here. Everybody uses Life in the Fast Lane. Please use Life in the Fast Lane if you're curious, if you want to read more. It's one of my favorite websites to just dive into and just get lost, because it's endless when it comes to ECG knowledge. And the second website was just something that I used for some of the pictures.
Okay, excellent. Thank you, Cristina. Yeah, there's so much. I'm definitely going to go back and rewatch that. I'd forgotten how much. Not that I didn't know, but how much I've forgotten since I started or stopped.
I absolutely
studying.
love it. Like,
yeah.
I don't know what made me just like ECGs so much. I used to not like them when I was a student, and somehow once it made more sense, because when I see an ECG, I imagine the heart 3D and just the electrical impulses going through the heart. And it's so quick, and yeah, I hope I've kind of passed on the passion, or at least the interest, because they can be quite dry.
No, that was really useful. And lots of people are saying thank you in the chat. I'm looking for any specific questions. As Cristina said, we will put all the recordings and the slides up on Medal, and then it normally takes me a few days to get it onto YouTube. I know there was one question earlier, which I think you may have touched on. It was from Salai. Where is it? Just going over how head injuries cause the prolonged QTC.
So, in terms of, again, your autonomic nervous system damaging your myocardium, unfortunately, that's more or less the length of the physiopathology that I can explain. But it's your autonomic nervous system that is at fault for that. So you raise the ICP secondary to your potential hemorrhage, secondary to the injury.
Okay, perfect. Hopefully that answers your question. I've also posted a link to the feedback form. Once you filled that in, you'll get a certificate of attendance. And I can see that Zalai has said, thanks, I understand it now. So appreciate that. I've also dropped the same links in the Facebook group and also your email inboxes.
Thank you. I also have got a tiny curiosity before everybody leaves. Winky back can be normal when children or people are asleep. I had to do my peds cardiac rotation to find that out.
Wow.
Again, because of sort of parasympathetic system that kind of occurs outside of your REM sleep. Small curiosity.
How did you find that out? Was it just that an ECG was done on someone that was asleep, perhaps? Or...
So we had a patient that had cardiac surgery, had their pacing wires out, and for some reason they were still monitored whilst they were asleep. The second day after the wires were removed, I was like, I'm pretty sure this is... The nurse called me and she was like, this person is in a form of arrhythmia. Can you come and do an ECG on them? Because you obviously only see lead 2 on the monitor.
Yeah.
So I came, I did that, and I was like, oh, this is Winky back. This is really cute. So I brung my reg, and I was like, look, is this something that I should be worried about? And she's like, nope, that is absolutely fine. It's very unlikely related, as long, obviously, as the child's fine. She was nicely comfortable in the sleep and reactive. It's fine. I was like, oh, okay. Literally, nobody in the cardiac department gets excited about Winky backs when people are asleep. As long as it normalizes when they're awake, obviously.
That's so interesting. Okay, well, I can't see any questions coming in, but thank you very much. Please do fill out the feedback forms. We do read them. It's really useful for us to improve things, and also it's useful for Cristina's portfolio. It provides evidence. Excuse my small dog barking at birds outside the house.
Oh,
there is a question from Dawn. Can you see that, Cristina?
Yes, and I'm looking to share a small thing. I'm just going to share my screen, but so if you think about lead V1 and lead V2, they're the leads that are on the right hand side of your chest. Well, especially V1 on the right side of your chest. So if you think about your repolarization and when that occurs, what would bring the repolarization wave towards the right hand side of your heart? So you can think about RVH. So think about you have physiological RVH up until more or less day 7 because of your fetal circulation. But if after day 7 you don't have, your T wave doesn't flatten or become negative, then you would be thinking about pathological RVH if your T wave is positive in V1 plus minus V2.
Okay.
The reason why I show that was because I'm a visual person. I learn. If I see someone's face talking at me, I usually don't remember anything.
No, definitely always useful to have.
So literally,
imaging.
T wave is positive just below 7 days of age, or should be, could be if you've got RVH.
Okay, well, I think we'll wrap things up there. So thank you all very much for attending. Thank you, Cristina, for a wonderful presentation.
It was useful.
Hopefully, I will be posting on Facebook, your email inboxes, whatever, with details of our next session. Enjoy your evening.
Thank you.